All right, future medical professionals, buckle up. You've just stepped into the deep dive, your express lane to mastering complex medical topics.
Mm-hmm.
Today, we're tackling something absolutely foundational: viral hepatitis. Our mission, especially for our dedicated first-year medical student listener, is to turn, well, a stat of detailed medical sources into clear, actionable knowledge.
That's right. We're talking the 5 main viruses, A, B, C, D, and E.
Exactly. And we're not just aiming for facts. We want understanding, retention, and, rock solid recall. We'll use anchors, metaphors, maybe some questions to keep you thinking.
Definitely. And to really get into viral hepatitis, we have to start with the liver itself. This incredible organ, it's nestled up there in your right upper quadrant, the RUQ of the abdomen.
It's our house.
Totally. It's doing so much, synthesizing bile, storing glycogen, making clotting factors. I mean, the list goes on.
So hepatitis just means inflammation of the liver, the hepatocytes.
Precisely. Inflammation of those liver cells, the hepatocytes. And today it's the 5 main viral causes, A, B, C, D, and E. So here's something to think about as we go. Given all those liver functions, digestion, clotting, everything, what do you think might be the most common sort of overarching sign that the liver's in trouble no matter which virus is causing it?
Okay. I'll keep that in mind.
We'll circle back to it. And one more really key point. All these viral hepatitis infections, they're notifiable diseases. You have to report them to public health authorities, like the UKHSA here.
Right, which really underscores their importance beyond just the individual patient.
Yeah.
Okay, let's kick things off. Hepatitis A. What's the story here? Is this the quick one?
You could say that. Hepatitis A virus, or HAV, it's a non-enveloped, single-stranded RNA virus. It gets into those hepatocytes, replicates, messes things up, and causes inflammation.
Okay.
So for a memory anchor, think hepatitis A is for acute and always oral fecal.
Always oral fecal. That points straight to transmission, doesn't it? Contaminated food, water, that kind of thing.
Exactly that.
Yeah.
Super common for travelers going to areas where it's highly endemic. Think the Indian subcontinent, sub-Saharan Africa, Middle East, Southeast, and East Asia.
Right.
Although, interestingly, many adults in those places actually got immunity from being exposed as kids.
Ah, okay. Any other risk factors besides travel?
Yeah, definitely.
Yep.
Certain sexual activities, like among men who have sex with men, or analingus. Also, people with hematological disorders getting certain blood factor concentrates, occupational risks for lab or sewage workers, and IV drug use.
Got it. So someone gets infected. What does that look like? Is it sudden?
It usually unfolds in phases, almost like a 4-act play. First is incubation, about 30 days. You feel fine, totally asymptomatic.
Okay.
Then comes the prodromal phase, maybe 3 to 10 days. This is where you get those vague, flu-like symptoms. Fatigue, maybe some joint pain, low fever, nausea, vomiting, discomfort in the RUQ.
And then the more obvious signs appear.
Exactly. Act 3, the ecteric phase. Lasts maybe 1 to 3 weeks, sometimes up to 12. And this is where you see that big sign we hinted at earlier. Jaundice.
Ah, the yellowing. So that's the common sign.
That's the classic one, yes. Yellow skin, eyes. You also get pale stools, really dark urine, maybe itching pruritus, and the liver itself can enlarge. That's hepatomegaly.
Okay. And the final act.
That's the convalescent phase, recovery. Can take up to 6 months, though. You might still feel run down, weak, not much appetite, some tenderness over the liver. But it's important to remember, lots of kids, and maybe half of adults, they don't even show symptoms.
And it usually resolves on its own.
Almost always, yes. It's typically self-limiting. Doesn't become chronic.
So how do we actually confirm it's HAV, and what do we do for the patient?
Diagnosis is mainly through antibody tests. We look for HAV IgM that tells us it's an acute current infection.
IgM. I'm gone soon, like acute.
That's a great way to remember it. And then there's HAV IgG. That means you're good. Either you had it in the past and recovered, or you've been vaccinated. IgG means immunity.
Okay. IgM acute, IgG immunity. Makes sense. What about LFTs?
Liver function tests, yes. You'll typically see ALT levels shoot up. That's alanine aminotransferase, a liver enzyme. Bilirubin will be high, causing the jaundice. ALP, alkaline phosphatase, might be up too. And the prothrombin time, PT, might be prolonged, showing the liver's struggling with clotting factors.
And management, if it's self-limiting.
It's mainly supportive care, rest, fluids, maybe paracetamol for pain, but carefully, considering the liver. Antiemetics if they're very nauseous.
Right.
Key advice for the patient: avoid alcohol completely. Stay off work or school while infectious. Strict hygiene hand washing is critical, and definitely no food handling for others. We also monitor their LFTs to see them come back to normal.
And prevention.
Vaccination is a very effective vaccine. Recommended for those at-risk groups, travelers, people with chronic liver conditions already, high-risk sexual activity, certain jobs, IV drug users.
Okay, that covers Hep A pretty well. Acute, oral fecal, generally self-limiting, but needs careful management and has good prevention. Now, hepatitis B. You called this the big bad B sometimes. Sounds more serious.
It often is, yes. Hepatitis B, or HBV. It's a different B. It's a circular, partially double-stranded DNA virus. And globally, it's the most common liver infection.
Wow.
The numbers are, frankly, staggering. Nearly 300 million people living with it in 2019. Over 800,000 deaths that year, mostly from the long-term consequences like cirrhosis and liver cancer, hepatocellular carcinoma, HCC.
That's huge. 42% of global cirrhosis burden.
Exactly. The highest burden is in the Western Pacific and African regions. It's often silent for decades, which makes it such a challenge.
So your anchor for this one?
Think HBV is the big one, spread by blood and babies, causing a serious global burden.
Blood in babies. That clearly points to transmission. What are the key routes?
Perinatal is a major one with a baby at birth. Sexual transmission, especially MSM or multiple partners, sharing needles for IV drug use.
Okay.
Also, living in or traveling to those high prevalence areas, incarceration, having family members with HBV or already having chronic liver disease or HCC.
And clinically, what does it look like? Acute versus chronic.
Acute HBV can give you weight loss, fever, fatigue, nausea, anorexia, that RUQ pain again, jaundice, sometimes a skin rash. But the really tricky part is chronic HBV.
Because it's often silent.
Exactly. People can have chronic HBV for years, decades even, with no symptoms at all until, bam, they develop cirrhosis or liver failure or HCC. That's why screening high-risk individuals is so vital.
Okay, screening brings us to the serology. This seems like the really complex part for HBV. You mentioned HBsAg, anti-HBs, anti-HBC, IgM, anti-HBC, HBB, HBB, HBV, DNA. That's a lot of markers.
It is, but we can break it down. It's like pieces of a puzzle.
Yeah.
So here's a question for you. Thinking like a doctor in clinic, you get these results back. How do you quickly figure out, do they have an active HBV infection right now? Are they immune because they got the vaccine? Or are they immune because they fought off a past infection?
Right. Those are the key scenarios. Okay, let's try. You said HBsAg is the surface antigen, and your anchor was S for surface, S for sick.
Perfect. So if HBsAg is positive...
Active infection, they're sick. Got it.
Now, what if HBsAg is negative? But anti-HBs, the surface antibody is positive. Your anchor.
S for surface antibody, S for safe. So they're immune, protected.
Right. But immune how? Vaccine or past infection, what's the tiebreaker?
Ah, that must be the anti-HBC, the core antibody. C for core, C for current, or cured from infection. You said this one isn't positive after vaccination.
Exactly, you nailed it. So if anti-HBs is positive and anti-HBC is positive?
That means they had the actual infection in the past and cleared it. Immunity from infection.
Bingo. And if anti-HBs is positive, immune, but anti-HBC is negative.
Then the immunity must be from the vaccine because they were never actually infected with the core part of the virus.
Fantastic. You've got the core logic. Just a few more details. IgM anti-HBC specifically flags a recent or acute infection, usually within the last 6 months.
Okay, IgM for the recent core exposure.
Then there's HBAg, the E antigen. Think E for evidence of replication. High infectivity if this is positive.
And anti-HB, the antibody against E.
That implies lower replication, lower infectivity, often seen when the infection is becoming less active or moving towards clearance. And finally, HBV DNA level tells you the actual viral load, how much virus is circulating.
So many pieces.
It is. And remember, you always interpret these results alongside the patient's symptoms and their LFTs. LFTs can go up and down or even be normal in some chronic phases. It's the whole picture.
That really helps break it down. So prevention is vaccination giving that HBsAg to stimulate only the safe anti-HBs who gets vaccinated.
It's recommended for high-risk groups, similar to Hep A risks, plus healthcare workers, infants. Universal infant vaccination is key in many places now.
And management, acute versus chronic.
Acute is mostly supportive again, unless it's really severe, like acute liver failure, bad ascites, or encephalopathy. then antivirals might be considered.
In chronic.
For chronic HBV, the goal is usually lifelong suppression of the virus. We want to get that HBV DNA undetectable, stop liver damage progressing. We use antivirals like PG interferon or pills like tenofovir or entecavir.
Oh, gets those.
Generally, patients with evidence of active liver disease like cirrhosis or high ALT levels, or those with high viral loads, high HBV DNA, or positive HBV. Also really important to treat pregnant women with high viral loads to prevent passing it to the baby.
Okay, a complex virus, complex management, but crucial to understand. Let's shift to hepatitis C. You said the C is for chronic, but also curable.
Yes, that's the big news for hepatitis C, or HCV. It's a single-stranded RNA virus enveloped. And like HBV, it often leads to chronic infection. But the game changer, we now have incredibly effective cures.
That's amazing. So the anchor HCV is C for chronic, but now also curable. How does this one spread? Still bloodborne?
Primarily, yes. Blood exposure is the main route. IV drug use is a huge factor.
Right.
But also sexual activity, mother-to-baby transmission, though less common than HBV, sharing things like straws for intranasal drug use. And historically, blood transfusions or unsafe injections before good screening came in, sort of pre-1992 in many places.
Who's most at risk?
People who use IV drugs, definitely. Those who receive transfusions way back. People who have lived or traveled in high-prevalence areas like parts of Africa, Asia, the Pacific. Babies born to HCV moms, prisoners, people with HIV, MSM, healthcare workers via needle sticks.
And the clinical picture, is it also often silent?
Very often, yes. Acute HCV, most people don't even know they have it, totally asymptomatic. Maybe 30% get some fatigue, jaundice, raised ALT. And about 37% actually clear the virus on their own within a year or so.
But the rest?
The majority, unfortunately, develop chronic infection. That means the virus, the HCV RNA, sticks around in their blood for at least 6 months. And again, they're usually asymptomatic for ages.
Until the liver damage shows up.
Exactly. Until they develop signs of decompensated cirrhosis, the jaundice ascites, hepatic encephalopathy, or they get diagnosed with HCC, liver cancer. HCV can also cause problems outside the liver, these extrahepatic manifestations.
Like what?
Things like a skin condition called porphyria cutanea tarda, vasculitis, which is inflammation of blood vessels, cryoglobulinemia.
Okay, so investigations. How do we find it?
We start with screening using an HCV antibody test. If that's positive, it means they've been exposed at some point, could be current, could be passed and cleared.
So how do you confirm an active infection?
If the antibody is positive, you then order an HCV RNA test. If the RNA test is positive, that confirms they have a current active infection.
No.
And of course, check LFTs, particularly ALT.
And the management? The cure.
This is where it gets exciting. Basically, all patients with active HCV infection should be treated. We use direct-acting antivirals DAAs. These are pills taken usually for just 8 or 12 weeks.
Wow.
And they are incredibly effective. Achieving an undetectable HCV RNA level after treatment is considered a cure. Think of DAAs like the direct-action Avengers. They just wipe out the virus. It's truly transformed HCV care.
That's incredible progress. Okay, moving on. Hepatitis D. The anchor was D for dependent. What makes it dependent?
HDV is fascinating biologically. It's an enveloped RNA virus, but it's defective. It absolutely cannot survive or replicate on its own. It needs hepatitis B. It literally hijacks the hepatitis B surface antigen, HBsAg. It uses HBsAg as its own outer coat. So no HBsAg means no complete HDV particle. You can only get HDV if you also have HBV.
So transmission follows HBV routes. Blood, sexual.
Contaminated blood, blood products, percutaneous, permucosal, sexual routes. Same risk factors as HBV.
And you mentioned 2 ways this dependency plays out. Co-infection and superinfection. Why is that important?
It's critically important because the outcomes are vastly different. Co-infection is when you get hit with HBV and HDV at the same time.
Okay.
This usually causes a more severe acute hepatitis than HBV alone, maybe even acute liver failure. But it usually resolves, and only about 2% go on to chronic HDV. It's like, as I said, they arrive together, cause a big scene, but mostly leave.
Right. And superinfection?
Superinfection is when someone already has chronic HBV and then gets infected with HDV. This is much more dangerous.
How?
It often presents as a severe flare-up of hepatitis in someone thought to be stable. And crucially, progression to chronic HDV happens in almost everyone, like 90% of cases. HDV crashes the existing HBV party and becomes a permanent, destructive guest.
Leading to faster cirrhosis and complications.
Much faster progression to cirrhosis, liver failure, and HCC compared to HBV alone or HBV-HDV co-infection. The clinical picture ranges widely, but superinfection is particularly bad news.
So investigating this dependent
You
virus.
need to test for HDV markers, anti-HDV antibodies, IgG and IgM, HDV RNA to check for active replication, maybe the HDV antigen early on. But crucially, you always do this alongside the full HBV serology panel because you need to know the HBV status.
And management for this double trouble.
It's tougher. The main treatment is pegylated interferon alpha, IFN alpha. It's not as effective as the DAs for HCV, unfortunately. Okay, last one. Hepatitis E anchor. E for enteric and erratic. Enteric like Hep A.
Exactly. HEV is another RNA virus, not enveloped, and it's also transmitted mainly by the fecal-oral route. Contaminated water is a big source, especially in endemic areas.
Where is it most common?
More common in Southeast Asia, Africa, Mexico, parts of Asia like Hong Kong, China. It's considered rare in places like the UK, although we are seeing more cases, often linked to, interestingly, undercooked pork products in some genotypes.
So usually mild.
Typically, yes. Most infections are mild, self-limiting. The virus usually clears within about a month, often no specific treatment needed. Chronic HEV and liver failure are rare, mostly seen in people who are significantly immunocompromised, less than 5% of cases.
Okay, so here's the question then. If it's usually mild and self-limiting, why the special vigilance? Why is it erratic?
Ah, that's the key. The erratic part comes from its surprising extrahepatic manifestations, problems outside the liver.
Really? Like what?
It can cause neurological issues, things like brachial neuritis, nerve pain, and weakness in the arm, Guillain-Barré syndrome, GBS, inflammation of multiple nerves, even meningoencephalitis.
Wow, serious neurological links. Anything else?
Yes, kidney problems like glomerulonephritis, blood issues like low platelets, thrombocytopenia, or cryoglobulinemia. Even acute pancreatitis has been linked to HEV. So while the liver part might be mild, these other things can be severe.
That really changes the perspective on HEV, so diagnosis and management.
Diagnosis involves HEV RNA testing or checking serology for IgM and IgG, alongside the usual LFTs showing raised all test. Because of those extrahepatic links, you should consider testing for HEV not just in acute hepatitis, but also if you suspect drug-induced liver injury or in cases of unexplained brachial neuritis, GBS, encephalitis, especially if the LFTs are also up.
Can't treat.
For acute HEV in someone with a normal immune system, usually just supportive care, rest, fluids, avoid alcohol, most clear it fine. The antiviral drug ribavirin is really only reserved for those immunocompromised patients or the rare cases of chronic HEV that don't clear spontaneously. No vaccine widely available except one used in China.
Got it. Enteric but potentially erratic with those extrahepatic issues.
Exactly. So that was a whirlwind tour. We've unpacked the ABCDEs of viral hepatitis. Quick recap. A is acute, always oral fecal. B is the big one, blood baby's big burden. C is chronic but now curable. D is the dependent one, needs B. And E is enteric but can be erratic.
And if we connect this back, you see the diversity, right?
Yeah.
All target the liver, but they're so different in structure, transmission, whether they become chronic, and how we treat them.
Absolutely.
Understanding those transmission routes is just fundamental for prevention. And mastering the serology, especially for HBV, is key for diagnosis and managing your patients effectively. Each one demands a slightly different approach.
You've definitely now got a more robust foundation on viral hepatitis. Hopefully those anchors, the metaphors, the questions, they'll help you understand, retain, and recall this crucial knowledge when you meet it.
Absolutely.
Yeah.
And maybe one final thought to leave you with, thinking about that huge global burden, especially for HBV and HCV, and knowing that access to diagnosis and treatment varies so much around the world. What do you think is the single biggest hurdle we face in trying to eliminate viral hepatitis globally? And how could really understanding the distinct nature of each virus, like we've discussed today, help us tackle that challenge?
Something to definitely chew on.
Keep exploring those nuances. Maybe look into the public health side, the societal impact. It's a field with ongoing challenges and discoveries.